So I'll now summarise the data from the DREAMM-8 study that was recently presented at the IMS meeting in Brazil, and I'll focus particularly on ocular safety and management. So this is a phase 3 randomised study that involved patients with relapsed refractory multiple myeloma who'd received at least one prior therapy and had prior lenalidomide exposure. And these patients were randomised to receive either Belantamab mafodotin, or Belamaf for short, Pomalidomide and Dexamethasone, or bortezomib, Pomalidomide and Dexamethasone. So in the investigational arm, Belamaf was given at 2.5 milligram per kilogram on cycle 1, day 1, and then reduced to 1.9 milligram per kilogram every 4 weeks from cycles 2 onwards, along with a standard dosing of Pomalidomide and Dexamethasone. And in the control arm, bortezomib, Pomalidomide and Dexamethasone were administered according to just standard dosing, and both arms continued treatment until disease progression. Patients had a median age of 67 years, and all had prior lenalidomide exposure, with over 3/4 being refractory to lenalidomide and just under a quarter refractory to daratumumab. So relatively a heavily pretreated group of patients. After a median follow-up of 22 months, progression-free survival was superior in the Belamaf arm with a hazard ratio of 0.52. So this reflects a 48% relative risk reduction in progression or death. The 12 months progression-free survival rate was 71% in the Belamaf arm compared to 51% in the control arm. The most common side effect from Belamaf was ocular toxicity, which was typically reversible and manageable with dose delays and reduction. The ocular events were graded according to the CTCAE version 5, with ophthalmic exam assessment of keratopathy and visual acuity based on corneal slit lamp findings and changes in best-corrected visual acuity. Patients with grade 2 or 3 findings required a dose delay until improvement to grade 1, and then once improved, Belamaf was resumed at 1.9 milligram per kilogram every 8 weeks. And for grade 4 findings, that's a corneal ulcer, dosing them was then reduced to 1.4 milligram per kilogram every 8 weeks upon improvement. It's important to note that Belamaf generally affects the cornea, which is the outer surface of the eye, and as the corneum, the epithelium typically regenerates, the ocular toxicity reverses, and we do see this in routine practice. The primary symptoms was mainly blurry vision, and this occurred in about 90% of patients, but a decline in visual acuity below 20/50 that typically affects activities of daily living, such as reading or driving, occurred in around a third of patients. And at the time of data cutoff, around 85% of these cases had already resolved. And over time, the dosing frequency had to be adjusted due to ocular adverse events, and around 90% of patients experienced at least one dose delay, and around 60% had their dosing frequency reduced to every 8 weeks or more. And with time, the majority of patients ended up receiving one dose of Belamaf every 3 months. And with this, we saw generally a lower incidence of ocular adverse events. Virtually all of the patients with grade 2 or more eye examination findings were able to resume Belamaf. And despite this dose delay, the effectiveness of Belamaf was maintained, and some patients even deepened their responses after 8 weeks or more of dose delay. So in summary, the combination of Belamaf, Pomalidomide and Dexamethasone is highly effective and superior to the current standard of care of POM, bortezomib and Dex for the treatment of relapsed refractory myeloma. And while the ocular toxicity is common, it is typically reversible and manageable, and without compromising the drug's efficacy. So I think that this combination of Belantamab mafodotin with POM and Dex will be a very important regimen for relapsed refractory myeloma patients moving forward.